do a brief introduction and then we'll move through the agenda. So welcome everybody. Thank you very much for your time and joining us to share the outcome of what was initially an 8-week project around data collection and protected characteristics. There's some housekeeping on the next slides, but I'm sure you're all very familiar with Teams and Zoom meetings nowadays. So I just wanted to share the genesis of this project, and it started, it brought together, I guess, two strands of actions and thinking. One had come from our data quality forum and some questions and comments about how we could find a way to make sure that protected characteristics didn't end up as a narrative entry in a patient records, but try and help clinicians and clinical teams and care teams in seeing the benefits of collecting this data in a way that was coded and therefore usable and searchable at a future date. And then the other part of the work was part of work with colleagues at the PSC and Roshan and his colleagues around interoperability in physical health checks for people who have a serious mental illness, often referred to as SMI, and trying to think about how in the last part of the financial year, when there might be a lot of pressures on clinical teams, we might find a way to maintain the focus on health checks, maybe through looking at the records and identifying those records that might have an entry missing, and then maybe the individual would have a check, health check missing that they could be called in to complete. So that was really the start, and the underpinning principle was really thinking about individuals with serious mental illness are not a homogeneous group. As a group, they tend to have worse access, outcomes and experience of healthcare. But within that group, there will be other groups that have even worse, or there will be subgroups that have even worse access, outcomes and experience of healthcare. And how could we try to support them better? So that was the start for our project, and trying to think how we could, through a data quality initiatives, really improve care. For people who might think, well, why is it relevant? You know, how does it transact in things I have to do on a day-to-day basis and some of the boxes I have to tick? Just very quickly, I think on the next slide or the one after, we've put together a few boxes that it may help to tick, which is there's obviously a data quality improvement, but even within our national colleagues and other colleagues, that is seen as the cornerstone in advancing mental health equalities. And within the red boxes, the protected characteristics or other fields that are not considered under the Equalities Act 2010 as a protected characteristics, where we have very low data and a requirement to focus now. Because we started thinking about primary care, there's the Tackling Neighbourhood Health Inequalities, DES, and we know that at the point where financial incentives stopped, the recording of ethnicity also started to decline. The patient and carer race equality framework, which has been at pilot stages up to now and should be implemented from next year, is again hinging on the fact that Mental Health Trust will work with their racialised communities to develop this framework, but they need to know who their racialised communities are. And then finally, more recently, as part of this round of operational planning, and if we can go, I think, to the next slide, Roshan, the Mental Health, Learning Disability and Autism Quality Transformation Programme as an expectation that colleagues in systems, in integrated care systems, will, by the end of the year, be able to establish a baseline of inpatient use for their population cut by protected characteristics. So these are some of the practical applications. but I will stop now because I want to leave the place for people who can really focus on the clinical care and the clinical interventions. Just wanting to say that we do have a bit of an interactive session at the very end, and we'll be seeking your views and your contribution as part of some of the products we have developed. We're looking at an animation, so there will be an opportunity for you to contribute to the design of that animation. So I'll stop there, Roshan. I don't think I've forgotten anything.
That's perfect. Thanks, Olivia. So I can take us on now to the next section. So just to introduce myself quickly, my name is Roshan Shah, and alongside a few other colleagues from the PSC, I've been supporting Olivia's team on the recent Protected Characteristics project. So building on some of those policy drivers, which Olivia mentioned earlier, some of our work in this space has focused on those characteristics which have been prioritized nationally. So that includes disability, ethnicity, gender identity, sexual orientation, and accommodation status, the last of which is not a protected characteristic, but is an inclusion health group, i.e. a key vulnerable population associated with inequalities. So as data from the later end of last year shows, the Southeast has a lower accuracy for each of those characteristics compared to the national level, and in some cases it is clearly much lower than the highest performing region's level of accuracy. And when we refer to accuracy here, we're referring to patient data where characteristics have been completed with a valid and useful code. And by useful, I mean that the patient has not been marked as other or unknown or not stated, because those values don't actually tell us anything about their characteristics, and they therefore don't really help us to understand the inequalities or the makeup of the people who are accessing our mental health services. And so when we rank all the regions for those characteristics and combine that together, our visual map of England really emphasizes that there is room for improvement for data quality in the Southeast. And so when we started to dig a little bit deeper into that data, it gets quite interesting. On the one hand, there's a lot of variation across the country. And when we look at those pink regions there, which have the highest accuracy for each of the characteristics, there's a bit of variation in who is sitting at the top. However, when we take a step back, we can see that there is actually some clustering with the characteristics. So regions tend to experience similar levels of data quality in some of the same characteristics. So if we take disability code, gender same at birth, identity, and sexual orientation, we can see that most of the regions have clustered together near to the bottom end of the graph, not too far from 0% data quality in some cases. Whereas for gender identity and accommodation type, we can see them a little bit more in the middle of the group, with quite a few regions around 40 to 50% data quality there, or accuracy. And then finally, ethnicity has had the biggest push in recent years, and so it's relatively stronger in data quality compared to the other characteristics. However, this is still the national picture, and when you dig down into the regions, you'll find that there is a lot of variation between the individual providers too. And this is data which we've taken from the National Mental Health Services dataset. And so having then established that data quality picture, we met with several performance and data leads and clinicians in primary and secondary care. And we started to hear that there are actually a lot of people who haven't heard much about why this is important in the first place. They haven't really seen anything compelling to show why better data would be empowering for them and their services. And so that's why we set out to build up the clinical case for why we need better data in the first place for mental health services and patients in particular. And as Olivia mentioned, the SMI cohort is also really, really important there. So something to really bring this area of work back to the patient at hand and about making it about the care that they receive. And also something to hopefully help win hearts and minds that this is an important issue that we should be focusing our attention on. So our clinical case report brings together some of the national and academic research, which provides evidence that health inequalities do exist and they exist across prevalence of illness, across access to services, and the patient experiences and outcomes from treatment as well. But the heart of our message here is that despite in the indicative national picture, there's actually still a lot we don't know and can't examine because we don't have enough good quality data locally, and in particular for the Southeast. So we did an exercise to identify some best practice examples of how local services, provisions, interventions can actually target and reduce mental health inequalities for some groups across our characteristics. And this hopefully helps to just bring to life the end goal here, which is to advance equalities. Ultimately, I think our message is that that is very difficult to do when we don't have the data to understand those inequalities in the first place. So that sort of led us to developing this clinical case. So for each characteristics, as I've said before, we've looked at some of the major disparities in the prevalence of mental health conditions between groups. So really thinking about how certain determinants are driving inequalities. We've then also looked at some of the barriers being faced to actually access healthcare services for diagnosis and treatment. So really trying to think, where are those barriers or bottlenecks in the sort of patient journey? Then the evidence shows that even where patients are accessing services, there are systematic variations in the actual experiences that they're having and the health outcomes of different groups. And so really trying to unpick why that's going on, or at least point us in the right direction of where to investigate further. And then finally, we've identified some individual case studies that show measurable or measured impact and improvements on inequalities that just give a bit of a flavor as to what we can learn and who we can learn from elsewhere in the country. And so now I'm just going to show you one example of a slide from our clinical case. And this is specifically a slide looking at ethnicity. And within that characteristic, one of our sections on experience and outcomes. So there's a lot going on here, but basically the data shows that there are significant disparities in outcomes for ethnic minorities accessing mental health services in this country at various levels. So whether that relates to administrative processes or experiences in dealing with health and social care professionals, as well as just in terms of patient health outcomes and improvements once they've received treatments. So lots of different angles at which inequalities currently exist. And so on this slide, we've just shown two illustrative examples of data here to show how this is true. So on the left-hand side, the graph on detentions under the Mental Health Act, which include people who were detained or sectioned in hospital for assessment or treatment, that data shows that the Black and mixed ethnic groups have a substantially higher rate of detentions, which corresponds with a sort of disproportionate adverse effect on that ethnic group or population. And secondly, on the right-hand side, you can see data which illustrates the proportion of patients experiencing an improvement in their mental health condition following therapy for anxiety or depression. And once again, there are statistically significant variations in that impact of treatment with, for example, Bangladeshi groups seeing a significantly lower improvement there. And so I think both of those data points show that there are clearly routes for further investigation to actually unpick what is going on in both of those trends, but having the data to even identify these issues and inequalities in the first place is really, really important. And without that data in the first place, we would be in the dark on some of these issues. So this is why we're trying to make the case that with better data and understanding, we could actually identify what is driving some of these variations in experience and outcomes, and hopefully improve delivery of care in the long term. And so this is just one illustrative slide out of many within our wider clinical case, which we would hope to sort of circulate and share more widely. This second illustrative slide from our clinical case report shows some Southeast specific examples of services and interventions being delivered by different organizations, both in the voluntary sector as well as some NHS partnerships, just to show what the actual end goal here looks like and bring this to life a little bit more within our case. So whether it's doing more to support individuals who have been identified as having learning disabilities, or directing patients to mental health helplines in their native or preferred languages, there's already really great initiatives out there aimed at tackling some of the inequalities that have been identified. And so this shows how some of the information on characteristics can actually be used in a number of different ways. So the first of those is that services could use the information about a patient's identity and life circumstances to actually improve their individual care. So if an individual was seeking mental health support and they chose to disclose that they identify as LGBTQ+, a health professional could confidentially direct them to the BU project, which offers LGBTQ plus specific services in Kent and Medway, and is a really great resource for that specific group of people. Alternatively, by having this data available on a local scale, we can use that to improve health services more widely through research and planning. So if we are aware that there is a large population of people who are homeless or rough sleeping in a specific area, then services such as the discharge to assess in Sussex can be planned to really support that population to transition. In this case, that's from acute wards into the community and making sure they receive the right support to finding accommodation alongside that. But that's just one example of how having that data and really knowing the makeup of the population accessing services or just living in an area can really help in the planning of those services and making them better. So hopefully this just gives people a real picture as to why this data matters and what the end goals are around advancing equalities. These are a few Southeast examples, but within our clinical case, for each of the characteristics, we've also gone beyond the region just to look across England and see some examples of services that have really nicely quantified and measured their impact to show how data plays a role in setting up and delivering these great services. Finally, I know that we are a health system nationally that is under a lot of pressure right now. I'm sure that many of you here today have very limited time as it is, and that's true for a lot of the clinicians and support staff who would need to be involved to make changes to data quality here. So what are some of the actual compelling benefits beyond what I've shown here from making progress on this sooner rather than later? So firstly, we would sort of put forward the case that tackling inequalities will help to improve outcomes and lower acuity over time. So our evidence shows that some groups are experiencing very high rates of mental illness. For example, they're struggling to access services and experiencing poorer health outcomes after treatment. So if we can tackle some of those inequalities earlier on and improve access and outcomes at an earlier point, that could help to lower the number of acutely unwell patients who are currently ending up requiring services potentially further downstream than they could in an ideal world. Secondly, there is existing evidence which shows clear links between high intensity use of A&Es or emergency departments and wider inequalities across issues such as mental health conditions, but also homelessness and rough sleeping and other factors. So reducing some of the inequalities here could also help in our efforts to reduce what can often be quite costly high intensity use of A&E services, and sort of just change where people are entering the system and accessing their services from. Thirdly, the evidence also shows that there are substantial cost burdens associated with these inequalities. One striking statistic from the clinical case was that one of the estimations in our research says that £1 in every £8 spent on long-term physical conditions is linked to poor mental health and well-being, which is quite, I think, an interesting and potentially even, well, I think surprising to some, less surprising to others, figure there. And if we can improve access and outcomes earlier on, there's an opportunity to support the long-term financial sustainability within mental health services. And then finally, on funding opportunities. So when the long-term plan initially set out stronger equality targets, there are a number of different pots of funding awarded to ICS schemes, to local authorities, and other partnerships across different sectors. So with the upcoming long-term plan refresh and 10-year mental health plan, hopefully coming this financial year, I think we'll all be waiting to see if there are any extra funding pots for initiatives specifically focused on tackling inequalities. And if that is the case, then having the right data to make the case for that funding and actually get going with initiatives sooner rather than later will be really, really important. And so that's why we're trying to sort of encourage organizations, providers, teams to think about this sooner rather than later and get that ball rolling. So on that sort of final forward-looking note, it's clear that health inequalities are moving closer and closer to the forefront in terms of our national priorities. So hopefully our clinical case and the work that the whole region has done in this area can help champions in providers, councils, systems, a lot of the people who are sort of on this call today, really make a compelling case to collect better data and take those initial steps forward. So as I said before, we'd be really keen to sort of start sharing that clinical case more widely after this session, but also keen to hear any feedback as well. So always happy if anyone wants to drop a line there. So thank you. And I just wanted to maybe ask if there were any questions on that work.
Whilst we're looking for, oh, we've got Claire. I'll come to you, Claire. I was just going to say that one of our goals today was to give some really practical examples and I said some practical output. So we will share the material. As Richard has put in the chat there, this will be recorded and available along with all the materials on a public facing website. So people will be able to download what they would like to access if it's relevant or of interest. Coming to you, Claire.
Yeah, thank you. I think it's really useful information. I think it's really great to have that sort of clinical context of someone that comes from a data background trying to drive it from a sort of data quality point of view, to have that balance and drive the clinical eggs is excellent. I wonder whether there was an opportunity on this the feedback of the slide around the sort of disparities that you shared with ethnicity, to actually socialize from a data point of view the gap. You referred earlier to the amount that's not there, that but yet the visuals you shared showed what we do know, not what we don't know, and actually that might help again drive that message a bit more if we could socialize it a bit more, that we know how many detentions are Black and Black British, I think was the top one, and etc, but we're not showing how many we don't know from that, that aren't replying with that accuracy point of view. And I just think being able to slice it that way and visualize it and socialize it out there that way would be really helpful to support the message, would be my only comment.
Thanks, Claire. That's really, really helpful feedback. And I think something we can absolutely do. I think it raises a really good point there, that actually some of the research that we pulled into the clinical case is based on where we have maybe 40% of the ethnicities of the patients. And so even though that 40% of data tells a really important and interesting story, maybe we can do a little bit more to sort of put the focus on that 60% of missing people who we don't have any data on, to actually sort of see what's going on as a full picture. So yeah, thanks, Claire. Really great point.
And I wonder, in a way, Claire, whether our next speaker, Victoria, who's joining us from Sussex Partnership, might in sharing the trust zone journey, address some of your points. And that's we've got fantastic speakers today. So we've got Victoria from Sussex Partnership and Liz from Surrey, bringing their own example of how they've worked either to improve data quality around protected characteristics, or when we come to Liz, about how you've built the case to address some of the inequalities within the cohort of people with serious mental illness using that rich data. So unless there are any other questions, and we can pick them up in the chat, over to you, Victoria.
Thanks, Olivia. Good afternoon, everyone. I'm Victoria Ray, and I, as Olivia said, I work at Sussex Partnership, and I'm a nurse by background, and I lead the business intelligence team at the Trust. And I think just listening to Roshan speaking then about you know, the possibilities for the future, it's really nice to think about those things, because I think it's quite inspiring on a journey that can feel like quite a long road. And I suppose where we are as a trust is quite early on in that journey, in terms of starting to think about some of those challenges and building that cornerstone of really good quality protected characteristics data. And I was smiling when Roshan was talking about the sort of non-answers. One of the things our work has led to is the removal of non-answers from our patient records. So it's really getting much easier for clinicians when they're talking to service users to be able to see where data are and aren't recorded, because before we had answers like not known or not stated, which don't really tell us anything. So that's been a really nice quick improvement that we've been able to do. What I wanted to do today is use my time with you to share the experience of undertaking this work with protected characteristics. I really wanted to relate to you the main challenges that the Task and Finish group has worked through and what we've learned along the way. So what I'm really trying to do today is share with you the advice I would give myself if I were to go back in time and have a quick chat with me just before we started out on this work. So I've just got one slide, and if we can put it up, that would be great. Thank you. So I hope, together with the blueprint documentation that Roshan and the team at the PSC have assembled, we'll be able to provide you with some really useful information if you're looking to start similar work in your own organisations. Specifically today, I'm going to talk about the work undertaken to create the definitions within our electronic patient record for each protected characteristic. That is, how each characteristic is described and what are the options available within the patient record for recording patient responses. So in taking this focus, I don't want to underplay the technical challenges of the work that we've done. We've had to do a lot in terms of matching data flows between our systems, of optimizing data capture and wrangling with legacy system design. And this work continues as we are harmonizing our data categories between our systems, and we start to think about how we combine our data sets with those of partners outside of the boundaries of our own organisation, so that we can all understand better their sort of health inequalities picture at the system level. So in the blueprint pack, you'll find a lot of detail about the drivers that came together to make improving the quality of our protected characteristics a trust priority at Sussex Partnership. Executive level sponsorship for this work and the governance structures supporting it have been really important. Having the mandate of a trust breakthrough objective for improvement brought a lot of focus around protected characteristics data, which is an area that's possibly suffered a little bit by being everyone's business and no one's particular responsibility. So alongside this mandate of having a trust objective, we created a really robust governance structure to wrap around the work, and that's been really vital in supporting the Task and Finish group to navigate some very complex decision making. So the first experience I want to share with you is the one that showed us that this is not going to be simple. That is, there's no definitive right or wrong answers around protected characteristics, and that robust governance is critical to support the decisions you'll need to make. So we started our research in preparation for the first Task and Finish group, and one of the first things that we discovered is there are no consistent definitions for the 9 protected characteristics in the Equality Act. The definitions differ between the Office for National Statistics that gives us our census data, the government design standards based on the government statistical Service, the mental health minimum data set was different again, and so was the NHS data dictionary. And so we'd kind of gone out thinking there's lots of good places to find the definitions we need. And when we started looking, we realised that actually there's quite a lot of variation. And I can't really count the number of times we sort of looked at each other and said, surely someone's doing this already. And the truth, as far as we can tell, is that nobody's been doing it, not in the way we need to do it anyway. So we'd expected to be able to take some proposed definitions to the stakeholder task and finish group based on work elsewhere. But with there being no off-the-shelf sort of solutions, we ended up needing to take quite a big step back and needing to understand the problem we are trying to solve in order that we were able to start designing the right solution for our organisation. And the decision to start by developing a very clear shared understanding of why we wanted to capture these data proved to be a very wise one. Having defined the problem we're trying to solve by capturing protected characteristics data, we were then able to describe the conditions that must be fulfilled in the capture of these data so that we can do it safely and effectively. We went back to the conditions that we'd outlined time and time again as we developed the definitions for each protected characteristic. And doing this really helped us to decide whether the definition we were proposing would allow safe and effective data capture and put us in a position to address our ultimate aim of reducing health inequalities. For our organisation, we determined that our definitions needed to meet the following conditions. Our definitions needed to allow us to fulfill our duties under the Equality Act. So that meant being able to capture data which showed us that the delivery of our services, showed the delivery of our services with an understanding of where inequalities related to protected characteristics might exist. So it needed to give us the data to support us to address these issues when we found them as well. And I'd also mention at this point that we also took the opportunity to add in armed forces status data into this work. We have the Armed Forces Act came into force in 2021, and so it's very similar to what we needed to do under the Equalities Act. So we brought that in as well. The second condition we needed to fulfil was of equal importance, and that was to be able to fulfil our remit as a clinical healthcare provider. We recognised in this two things. One, that we are a healthcare organisation and must interpret equality legislation in light of our clinical remit. And two, that a person's protected characteristics data is going to be captured within their electronic patient record. And as such, it will be used to help inform clinical decisions at the individual level. And we also thought about how these individuals might be children or adults. And there's different kind of things we needed to think about there as well. And finally, it was really important to us that we defined our data categories and questions with sensitivity and in line with our organisational values. So examining why we're capturing the data and how it will be used and then developing these conditions took quite some time. It took 2 lengthy task and finish group sessions of dedicated work on this and additional work in between by the project team. So the second piece of advice that I would share from our experience is understand in detail the problems you're trying to solve by capturing protected characteristics data and what that means within the context of your own organisation. We had really strong engagement from the outset with this work, and you'll see in the blueprint pack our stakeholder task and finish group included clinical and service user representation, with people involved from across the full range of specialisms that we provide as a mental health trust. Additionally, we had data specialists, performance analysts, representatives of specialist interest groups, and equality, diversity and inclusion leads participating in the group. There was a really strong consensus within the group around the importance of capturing protected characteristics data to aid our understanding of health inequalities and support the delivery of high quality care. But there was often much less consensus over what would be the right definitions for the individual protected characteristics. We had not fully anticipated the emotive nature of this work, and we needed to respond really quite quickly when difficult issues arose during our first task and finish group meeting, so that we could ensure that the group continued to function effectively and that all participants felt supported and able to contribute fully to this work. Reflecting on this first meeting experience with members of the group and with the project team allowed us to recognise not just the complexity of the task at hand, but to also see that complexity within the wider picture of political and cultural uncertainty, particularly around characteristics such as sex and gender. Acknowledging these circumstances helped to diffuse some of the tensions and to confirm our shared determination to achieve the aim of being able to capture protected characteristics safely and effectively so that they could be used to address health inequalities. So to help the group work together, particularly where strongly held views diverged, we did a number of different things. We paid attention to the way the task and finish groups were conducted to help ensure that all participants felt able to contribute their views and that conversations were conducted in a kind and sensitive manner. We acknowledged that we all have protected characteristics and that members of the group may have had negative experiences which relate to one or more of their own protected characteristics, or that it might be the case that someone cared for by a group member, either personally or professionally, might have had a negative experience. Recognising this potentially personal nature of the work, participants were offered the opportunity to provide further contributions outside of the task and finish group, and then these contributions were fed back into the group discussions by the group facilitators with sensitivity to the fact that the contributor hadn't felt able to express these views openly within the group. Group members were offered support by the Equality, Diversity and Inclusion team, where they might have had an experience within the group discussions that was particularly affecting or distressing to them personally. And on a number of occasions, the task and finish group couldn't arrive at a conclusion about a particular issue, and so the project team were asked to go away and conduct further research or consult with expert groups so that they could bring that information back and we could continue the discussions. And this took quite a long time. We expected to have the changes in our EPR before Christmas, quite a bit before Christmas, and they've just gone in now. So it's taken a lot longer than we expected. So my final piece of advice is probably my most important, and that is be prepared for difficult conversations. Prepare your colleagues by acknowledging that there are a variety of views and that there's no right or wrong answers, so that you can pave the way for open, respectful and productive conversations. Our work isn't finished yet. In the next phase, we'll focus on how we support our staff to have a clear understanding of the purpose of capturing protected characteristics data and to provide them with the training and support that makes them feel confident and able to have conversations with service users about why we capture this data and how it will be used to improve the healthcare services we offer. And we'll also be using the next phase of work to actively seek feedback from service users and staff on the definitions that we've created. The definitions will remain open to review and will be updated where the evidence becomes available that they can be improved. So those are my pieces of advice and the sharing of our experience. If there are any questions, I'm happy to take those.
Thank you, Victoria. Very practical suggestions and hints and tips. Any questions? None immediately. So there's still the chat function, or we can take questions later on. As you mentioned, Roshan and colleagues have captured your journey into a blueprint that we will share, so there will be more detail available to other organisations that may be interested. Shall we go to you then, Liz, and hear about Surrey and your work in addressing inequalities within the SMI cohort? Yeah, thank you. In some ways, I'm kind of addressing the other side of the coin that Victoria was talking about, really, the so what following SMI health check. So I'm Liz Williams. I'm the system convener for learning disability, autism, and mainly adult mental health within Surrey. And a convener kind of starts to address the so what big issues. I'm working in the SMI space as the system SRO for physical health checks. As I am the SRO for LD annual health checks, you will not be surprised to hear that the SMI work that we did together with the PSC in Surrey was on the back of doing the same piece of work around learning disabilities and annual health checks, basically trying to work out what the data from these health checks were telling us about the health of our populations and the inequalities experienced by people with a learning disability, and then subsequently by people experiencing serious mental illness, so we could design interventions at neighbourhood, place and system level to consider the so what. As a result, the annual health check learning disability stuff is a lot further ahead than the SMI annual health check analysis. So I'm just presenting the analysis to you here today. I'll go through it quite quickly. I'm happy to take questions and have a discussion. But just to assure colleagues, this work has already gone into our JSNA chapter and got taken yesterday to a whole system population health management event, where we asked the question, you've had an SMI health check, so what? So this data has already been used, not as far as the LD annual health check data has, but certainly it's in the system. It's being publicly shared, debated and discussed, most critically with people with lived experience through our independent mental health network run by the fabulous Surrey Coalition that we have within Surrey. So that's kind of the context and where this data in this presentation's already gone and is starting to drive conversations about tackling health inequalities. Next slide, please. I'm going to turn into Chris Whitty of old, aren't I, asking for the next slide. Sorry, Roshan, I keep asking you. I mean, interestingly enough, I think we're trying to use this data to tackle the same issue, which is effectively premature mortality in people with a learning disability and people with serious mental illness, because as we know, that's the most stark inequality. As I've already started on the case for change, so next slide, sorry. I should have controlled my own. I'm being spoilt for a change. But the case for change was effectively, what is the data telling us about health inequalities and how can we address what the data is telling us? And when I talk about data, I don't just talk about the numbers. For us in Surrey, it is equally important to look at qualitative data as it is quantitative data. And a big part of this project with our PSC colleagues was actually surprisingly talking to people living with SMI and having experienced or not experienced health checks, as well as staff and clinicians on the ground. So in trying to do this project, we were looking at the gaps in understanding, particularly of the socio-economic drivers. And we did this work just before, I think, the cost of living crisis really hit. So it would be my request of our system that we then redo this work or we keep this very live, as I suspect some of those socio-economic drivers will actually have become more entrenched or even more of a barrier to experiencing good health outcomes, particularly for this group of people, than before. So next slide, please. Sorry, there's a pause. Let me get mine up. So the central aim was, in the way I've just described, the JSNA and the public health management event informing Surrey Heartland's strategic priorities when looking to combat health inequalities. So 3 stages, I've kind of mentioned some of them: the quantitative analysis of the data held within EMIS, our patient record, and any publicly available data. We did that more in depth in the LD space because EMIS was behaving itself at the time we did the analysis in LD. Wasn't quite so amenable to searches when we tried to do it in this space. The lived experience engagements, which were absolutely critical, and really thoroughly, I believe, more thoroughly inform some of the work that we're doing as opposed to the quantitative data. And then workshops with staff really is a bit of a check and challenge. And the 3 areas that we found were relating to primary care, relating to deprivation, you've heard me mention that already, but also about community assets. And we'll go on to the next slide if that's all right, and describe those a bit more. I think the next slide is the findings from lived experience and the themes. Theme 1 being, I want to receive more support around housing and employment. It's not going to come as a surprise to any of us, is it? And we have the fantastic long-term plan initiatives such as IPS to try and support people. And we connected very quickly into our mental health and housing commissioners, and in fact this data will also inform our housing JSNA. This isn't just going to sit quietly in a chapter about mental health. Our plan is to influence and impact everywhere that we can using the user voice that was kindly shared with us. Theme 2, I want to be able to navigate the system of community services available to me, and we're actually talking to the Hub of Hope, which we believe CNWL use, because not only is the system but also the community assets almost impossible to understand and to experience. And find out and work out what you need. Theme 3, I want to attend more casual groups, not just crisis management services. And that was a really big deal when we heard that as a system, and we're starting to really think about that. Just people being connected after COVID and how impactful that is to share experience and hear and listen to one another. It was massive, and we were all quite shocked, and rightly so, I think, about that particular theme. Theme 4, I want my care to have a greater focus on my mental well-being, not my illness, my mental well-being. Interestingly, I think one of the quotes was, I don't feel my GP cares enough about my mental health, but would rather manage my current state through medicating. Our primary care colleagues have taken that on the chin, and again were quite surprised about that, and are thinking about how they communicate with their patients and the people that they're supporting. And finally, I want more support to live a physically healthy life, and some of that theme has already been taken into some of the bids that we're putting forward into our mental health investment fund in Surrey. So even before we've got this into strategies, these findings are making a difference or looking at impacting. And our mental health investment fund is a pot of money put aside through Health and Social Care in Surrey to look at early intervention and prevention, and recognising that living a physically healthy and active life is incredibly supportive of both our physical and our mental health. So even before we've got this all into strategy, we're trying to chip away and make a difference. I think interestingly on this slide as well, we spoke to a wide range of organisations, including those supporting people with a learning disability, given the high incidence of mental health experience within that population. And also we spoke to the police, who gave us some fantastic insights, but predominantly people stepped forward with a really strong voice from the community of people with lived experience, for which we were really grateful. And actually they felt really heard and validated, particularly now that we can tell them some of the things that we've done to follow up. Next slide, please. So the next slide is kind of picking up on the findings relating to primary care. We were looking at the SMI register actually and doing some work on that. None of you will be surprised to hear that. But also looking at doing some cleansing on our SMI register, because it's really important that we didn't seek to re-traumatise some people who had one single episode of mental ill health, and then every year were being invited, and effectively telling us it was re-traumatising them to be invited to a health check. So we're looking at doing some really close work, and Olivia and I have had some conversations about that and getting that register into really good shape so that the physical health check reaches the person that needs it and improves their physical health, but it doesn't re-traumatise or not be the people who don't need it. I'm aware that the slide is stuck on my pack, so I'm not sure if you can see what I'm reading. I'm looking on my own slide, so forgive me if that's the case. Quantitative analysis found that the further away you live from your GP, the less likely you are to receive all of the checks that amalgamate into a full physical health check. Predominantly because public transport can be so expensive and time consuming, and I've taken that message into our transport teams within Surrey County Council, and we're going to look and have a think about that, because that's not great. We're also talking about whether a GP federation or a primary care network offer might be more appropriate, or a bus. The vaccination, we did really well in vaccinations, particularly for autistic people with a learning disability in Surrey. It's because people love the bus. So we're going to look at thinking about how we can make physical health checks even more accessible, or getting that full gamut of checks that make up the SMI check. Sadly, people told us they were really disappointed in their interactions with GPs and healthcare services. They felt the onus was on them to proactively reach out. But there was a really stark difference in the experience across GPs. And most people said they've never seen their health action plan. So that's a big message I'm going to have to take into Primary Care Transformation Board and start to think about really improving the quality. And as most of you will know, we're doing audits around the quality of annual health checks for people with learning disabilities. And I've reached out to see if any of you have an audit of the quality of an SMI health check, even though it's a very different offer. So if anyone's got anything, please, you want to do some work together, there's a shout out for me. Please come and help us. And our public health colleagues, yes, are working with us very closely. In terms of findings relating to deprivation, we found that homeless people were underrepresented, and you won't be surprised to hear we're already having conversations with our Changing Futures programme to see if we can increase that number, or find a different way to offer someone the physical health check that works for them. In terms of housing, we've already, as I said, started to lobby and use some of this data within our housing JSNA and within the Commissioner's work around supporting the development of more housing for people experiencing severe mental illness. You will not be surprised to hear that our trajectories and our models going forward give us a significant gap in the housing that we've got and the housing that we need. And that's really supporting our colleagues in Surrey County Council to think about that. Employment in Surrey, for every 1% increase in the unemployment rate, you would see an average increase of 6 people on the SMI register. What a stark piece of data that you can imagine I'm taking just about everywhere I can, particularly when we're looking at different models of support for employment. But there's that's quite a strong tie there, and having those conversations is really important. And finally, you won't be surprised to hear our police and crime colleagues, we were talking with them about an increase in the demand and use of Section 136. We've kind of caught that conversation up already in terms of the SHIP model that we have about police involvement in supporting mental health, and we've recently got some national guidance, haven't we, that we're going to have to think about how we support those whose expression of their mental ill health may bring them into contact with the police and criminal justice system. And so this will advise our future model going forward within Surrey with our Surrey and Borders local trust colleagues. And the next one, the findings related to community assets. I'm really pleased that the PSC and I have done loads and loads of work on the community assets, as well-being is only, I think Dr. Claire Fuller, Professor Claire Fuller, our AO, yesterday stood up at the public health event and said only 20% of health improvement happens within the health arena. So the community asset is the 80% opportunity to tackle any health inequalities and improve everyone's health and health outcomes. So GPs needing a formal understanding of community assets, that's where we're talking to Hub of Hope, but also working at place level to see what we can map already, and finding those resources a GP can refer someone onto, not just through the routes that we've already got, like social prescribing, using the ARRS roles, but giving that GP and the person themselves a list of places or things they can move on to or have choices about navigating what's on offer in terms of assets, and not health and social care assets. You know, where's your leisure centre? Where's your local Zumba class? I always refer to Zumba, forgive me. In terms of lack of trust, and relating back to Roshan and the work that we're trying to do, it was reported that people from minority ethnic communities did actually show slower engagement because of mistrust. So we're going to have to do some work on that. And I put in the chat earlier that part of our community mental health framework transformation, as we call it, GPIMS, they have engaged Surrey Coalition of Disabled People to start having those conversations with minoritised and racialised communities to see why they're not coming forward to seek support for their mental illness. And we'll start to have better conversations about building trust, and Surrey Minority Ethnic Forum have been really helpful in supporting us with that, and will continue to do so. Again, services not tailored to meet user needs. All the money and all the services are thrown at crisis management. And we're hearing that very strongly, which is why we've now got the Mental Health Investment Fund I referenced earlier, which is about early intervention and prevention and having a pot of money. And it's a significant amount of money, about 12 million quid in Surrey, that we are focusing on the communities bidding for a cut-off, if you like, to look at doing early intervention and prevention support. And we've got some great projects coming through, including co-creating health, looking at farms, the use of farms in some of our urban and rural environments to bring people together to have conversations. So really excited about that. And finally, the culture of healthy living, which was not widespread across this population. And that some people needed some support to encourage exercise and healthy eating services. Interestingly, some of the healthy eating stuff was not accessible due to budgeting constraints. Well, in Surrey, we've just put out into the system, I know for people with learning disabilities, it was 250 air fryers and slow cookers, with some classes about how to use them. I'm going to go to one of the air fryer cooking classes because I have one, and other than chips, I really need to learn to use it better. But developing that culture of healthy living and healthy food that doesn't need to be expensive but can be tasty and really important. So that was the findings related there to the community assets. Next slide. Olivia, shout at me if I'm taking too much of my time up, but these are the last couple of slides are the list of recommendations really that we formulated as part of the project. And then each recommendation will have an owner and a home by which it will be challenged. The oversight for this, given that Victoria was talking about governance, and we really need the governance, so we hold these recommendations. We hold ourselves to account as a system to make sure we deliver against these recommendations, is my SMI Physical Health Programme Board. But as I said, I already have another set of places to go and socialise these, and I will be naming people against the improvements and the key recommendations. You won't be surprised to hear they kind of relate to all of the themes. The SMI register, making sure it's accurate. Primary care comms. Community asset mapping, which I've spoken about already, looking at Hub of Hope and other models, engagement, tailoring those services to make sure people can afford the things that they're being offered, but also to make sure they're accessible, but they also meet people's needs. They're not all about that crisis end. They're about that positive early intervention, peer support, where communities co-create health together. It's not always about, and has to be about, service intervention, which is where that Mental Health Investment Fund will be so helpful. And then there's the second page worth of recommendations. Again, everyone will have a name and a lead, and we'll be holding them to account in the nicest possible way and supporting them in every way we can to deliver against their named recommendations. But again, they're about homelessness, they're about housing. I've already spoken a bit about the early conversations around employment, about looking at a blended approach. I mentioned the bus. Our vaccination numbers were huge because we had a vaccination bus, but also where else do people congregate? They could be comfortable to have the 6 or 9 elements of the health check, recovery colleges, for example, and then looking at subsidised travel. And finally, most critically, improving those interactions with primary care, with GPs, and enabling an open conversation about mental health in a way that's holistic. Because it's not one single offer of a health check in the same way that it is in the LD space, I do think our primary care colleagues expressed that they struggled as well to bring up those other elements like alcohol, for example, and smoking that are part of the check. But also using tech and digital. Does someone get a text message to say pop in and have a chat to me? There's 2 more elements for you to have your health check, and it's really important that we have a look then at a health action plan with you. So they're the sets of recommendations. There's the piece of work that we did. Really, thank you so much for the comments in the chat. Really helpful. Always happy to have conversations with people to follow up. But if you've got any questions or comments, please do ask them. And I'll put my email in the chat as well if you'd like to get in touch.
Thank you very much, Liz. I'll just ask whether there are any immediate questions. I know some people can only stay with us sometimes from 3 to 4, and we've already lost a few people, but let's just check whether there are any questions. There's comments in the chat. So hopefully what we've shared is, oh, fantastic, Steve has just appeared on screen. We're coming to the next section, but through Victoria and Liz, we've shared both a secondary trust journey and then what may happen from primary care. So how to get the data and get that consensus agreement about the data, and then what we can do very practically with that data to improve access, experience, outcomes of care. And sometimes, as you were saying, Liz, it's not through healthcare clinical routes, it's opening up horizons and linking people with their local communities, which is really important. So having heard those two very powerful examples, what we wanted to share with you was an outline of the resources we will make available, and then just test your views on a proposal or a proposed character for our animation. So shall I go to you first, Roshan, or shall I go to Steve?
Thanks, Olivia. I can kick us off for this section, and then I'll hand over to Steve for the video portion. I'm going to have a go at sharing my screen again, although the internet is a bit spotty, so if it drops, then please do shout. Can you see that all right? Yeah, okay, perfect. So yeah, so we're just going to, I'm joined today by Steve Hubbard from NHS Creative to talk about some of the support resources which we've developed for clinicians and commissioners, for health and care staff, for patient and carers, and just organisations more broadly. So those resources include the clinical case, which we've already talked about today, but also some other resources, including a flyer for patients and carers, staff materials, including an animated video to really explain why this work is important and why we need to collect better data in the first instance. And then finally, as Victoria mentioned earlier, a more practical blueprint setting out one successful methodology to get the ball rolling on improving data quality in Sussex. So these resources have had a lot of different inputs go into them. Throughout our work, we've spoken with performance and data leads and clinicians across a number of the ICBs or ICSs in the Southeast, a number of the trusts, and some GP practices within the region. So we've also drawn on previous engagement, which has been done nationally with patients, including from NHS Digital and Healthwatch, just to really understand patient concerns around data and where we can help to inform with some of our resources. So that has helped us to create our draft resources, which we are continuing to test with different stakeholders. So just to start off with, we have developed our patient and carer facing flyer. And the real purpose of that was to provide a clear, simple, jargon-free explanation as to why you as a patient might be asked about your identity and life circumstances when interacting with mental health services and how that information would be used. And our hope would be for this flyer to be adapted by individual providers or organizations' teams to tailor some of the information that is provided within it. So, for example, there's a section in the leaflet which gives an example of a local service aimed at specific demographic groups. So an example of this is the BU service, which I mentioned earlier in Kent and Medway, but we would want other areas to be able to adapt this to their own local services to make it as applicable as possible to their local residents. Our flyer provides information on what protected characteristics actually are, why we need to collect information on them, and what we use them for, and focusing on those two main aims, which I mentioned earlier, around actually improving individual care, but also improving health services more widely through research and planning. It also helps to respond to some of the concerns that patients commonly have around who will see their information and how it will be stored. We've made sure to be very clear that patients are also able to opt out of disclosing this information if they wish, and that they will still receive the same care if that's the case. And as part of developing some of these initial materials, we've also created some easy read adapted versions to make sure that they are accessible for as many groups as possible. And so now we're hoping to use more of our staff and patient networks and user groups to just continue testing our materials and make sure that the language that is being used is appropriate and sensitive to different communities across the protected characteristics. We've also developed a poster for health and care staff who are actually involved in the collection of data from patients, whether that's support staff, healthcare assistants, anyone else. And so this also clearly explains why they should care and take the time to collect this information, but also how to sensitively and appropriately do that. And so this accounts for the fact that, you know, many people accessing services are in crisis or are not in a position to disclose that information or be asked about their protected characteristics information. So hopefully our materials clarify that there is a right time and right place to collect that information. And we refer to some of the guidance that's been published nationally on how to actually go about that, particularly if a patient is in crisis, for example. And then finally, alongside our poster, we are collaborating with NHS Creative to develop an animated video to once again just really explain the value of this work and how we can tackle inequalities in the country. So I'm just going to pass over to Steve, who will just talk a little bit about where we are currently in the stage of developing this video and our central character and some of the considerations which are going into this.
Hi, thanks, Roshan. Yeah, I'm Steve Hubbard. I'm the marketing manager at NHS Creative. So we're a design and marketing service for the NHS. We're all NHS employees ourselves, and we have a team of graphic designers. So we regularly in-house develop animations. And what is unique about an animation is that it can really help to tell the story and explain the context of the reason as to why we've got this particular ask. So it's a good way of conveying everything that Roshan's expressed already, hopefully in a fairly dynamic format. So we're going to build on the work that Roshan's already explained to you. We'll feature some elements of the branding style that Roshan's already showed you. But central to the animation is the creation of a character called David. And we would like to get your thoughts on how David could look. So the first stage of any animation build is to create your central character. And it's good to have a character in any animation because it explains the impact on that person. So you may well have seen animations by the King's Fund. It's a very common sort of approach to explain a complex system by showing the impact it has on that individual. So that's what we want to do. And there's a number of ways in which we can approach this. The first step is to create the character of David, and then we'll create the world around him. So there's a few different styles that we've created. I don't know if you can go to the next slide, Roshan. That's it, thank you. 3 options, just basically a different illustrative approach each time. So the third option has been hand drawn. The first 2 options have been created digitally on the Mac, and just really would like to get your thoughts. I think this has been sent round already for people to look at, but if you've got a view on it, it would be great if you could vote or give us your opinion. And this is obviously the stage at which we'd like your input. Once we've got a decision on the way forward, as I mentioned, we will then create the world around David. So this is really the best point at which to give us your input and tell us if we're going on the right lines or not.
So, Steve, Richard has just put a QR code and a link to a Menti with option 1, 2 and 3 for colleagues on the call to use to vote. And I think on the previous slide, there were a couple of lines of explanation as to how we selected David. So the reason why David is from a Black Caribbean background and has a learning disability is recognizing the fact that, as Roshan said at the very start, a lot of Black men are disproportionately impacted by restrictive interventions, and sometimes, very often, it might be related to cultural misunderstanding around spirituality, or not getting the right care early on in the process and ending up with restrictive practice as opposed to early interventions. And also to the point that not all disabilities are visible, so it's really important to ask people and not assume any status when it comes to protected characteristics. So really open up that discussion and be able to let people choose whether they want to answer the question, not answer the question, but be in control of the response they choose to give. So Richard will be guided by you in terms of response rate. We've got about 50 people on the call at the moment.
Thank you. We've had 20 so far. We have got a clear runner, which is why I'm not sharing the screen. I don't want to bias anyone's opinion on who you choose. But I'm probably looking around 30 more responses possible.
Did you want to switch back to the next slide, Roshan, just so that people can see the options again? That'd be great, thank you.
Hopefully you can all see that again now.
Yes, thank you, Roshan. More votes are coming in, around 15 to go to get to that number of 50 odd.
So whilst people are voting, what are the next steps, Steve, in terms of the animation? So obviously choosing the central character is quite key. What's our timeline?
Well, we've got one of our designers we've got scheduled in to start working on this from the 1st of April. So we've got another week or so for any input. You know, if an option were chosen but with some adaptations required, then we can take that on board. And from there we'll then start developing the scenes within which David appears. There's also quite a few sections of the animation that are, should I say, a bit more generic or corporate. So we would be looking to build in like the infographics scene that Roshan showed from one of the material pieces earlier. So we would build that in. So there's work that we can be doing anyway before a character is decided upon, but this is a fairly central part of it, and we'll develop it from there. I think we've got a script that I think you sent round for comment as well, Olivia. So I don't know if you've had any specific feedbacks on the wording of the script, but that's very central as well. If there is any feedback, to get that at an earlier stage, it's much easier with an animation to you know, any thoughts or comments, we want them at the front end. It's much easier to take them on board than at the back end after the animation has been designed and built. We can still take feedback, but it's more time consuming to implement something if it's already been designed and developed. Does that make sense?
It does, thank you. Richard.
So yeah, voting seems to have slowed down or paused. So I'll share the screen at this point to see where we are. With a clear runner of option 2.
That's fairly conclusive, isn't it? I think.
It's still open, so if anyone does want to vote, please feel free to. And thank you very much.
Thank you. So coming back to you, Roshan, to finish off.
Yeah, perfect. Thank you very much. So I will just slide back up. Great, hopefully you can see that. Great, so thank you. And actually just maybe one final point is that as we've been in conversation with the NHS creative team and Steve, and started to think based on our script what that animation would look like, we're working hard to avoid the animation being stereotypical or tokenistic in any way. And so part of this process is just trying to get feedback to make sure that it is, you know, appropriate and sensitive in that way. So thank you. Great. So then moving on to our last output then, which relates to Victoria's talk earlier. So we have created worked together to create a bit more of a practical blueprint for improving data quality based on that methodology, which Victoria talked us through at Sussex Partnership Foundation Trust. And so we've developed this as a shareable PowerPoint deck, but also, as you can see from the images on the screen, we've also created a slightly snazzier blueprint report, which could be shared more widely in the hopes that not to be too prescriptive, but instead to say, this is how one trust has worked really hard to get this work on health inequalities and data quality onto their top strategic agenda and is starting to make real progress. So if you're someone who wants to do the same in your own organization, but you're wondering, where do I begin? This can be an example methodology that you could use to help guide you. And there are some really nice lessons in there, which Victoria talked about earlier, for those who wish to sort of pick this up and run with it. So our blueprint sets out the context and the case for change, which was established at Sussex before getting this piece going, and outlines some of the steps taken to really get, as Victoria mentioned, that trust executive leadership on board, make this a breakthrough objective with senior sponsorship. We've also got information there on the specific governance and the terms of reference that were put in place for the Task and Finish group to make sure that there was accountability, and perhaps maybe some of the most exciting bits are around the roadmap detailing some of the more specific steps taken and the conversations which happened, including a list of the different stakeholder roles that were involved. And it really is an impressive list. So hopefully if you take a look, that can sort of give some inspiration as to all the different people you can involve in a piece of work like this to make it as successful as possible. We talk a little bit about how systems and digital capabilities have been used to make change, such as changes to the EPR, and what reporting and benchmarking has been put in place or integrated into the existing reporting to monitor progress internally. And then finally, we have some detail on what SPFT are going to be prioritizing next, and some guidance on how other organizations could take a similar approach going forwards. And so I've just got one illustrative slide here from the slide deck version of this pack, which quite nicely sets out a potential phased approach that could be taken in Sussex's footsteps to really prioritize this work strategically, get the right groups in place to understand what's going on in the as-is or current state, and then move towards actually working directly with frontline staff and transforming processes over time to ultimately improve data quality. And so we will share this as well as our other sort of resources after this session, and hopefully someone somewhere can use this to sort of help make a difference. So I'll just leave this slide up and ask if there are any questions on this, and also to say, please feel free to reach out to myself, but also I know Victoria, Liz, and others have put email addresses in the chat or on the invite list as well, and we can all answer your questions.
So you've got a question from Hayley.
Oh, great. Hayley, do you want to come in?
Hi, I just wanted to check with regards to this. It looks great, but has it been thought about for the smaller providers like the voluntary sector and that actually how it can be helped with them? Because appreciating all the work that's gone into this, but Sussex is obviously a very big organisation with a lot of resources. What are we going to be able to do for the small providers? Has that been thought about, please? That's something we're struggling with currently. Thank you.
Thanks, Hayley. So with this blueprint in particular, I think it has probably, because it's been based on what Sussex has done, is more appropriate for those larger providers, although there some of the principles and some of the steps taken, I think will probably apply universally. And if any of my colleagues want to jump in on this afterwards, feel free to. In terms of smaller providers, so we actually, as part of this piece of work and our investigation, so to speak, we did speak to a few of the sort of people involved in trying to connect up smaller providers into this piece of work. And so we fed back some of our findings to Olivia and the regional team there. And so maybe the gears are still turning on what best resource or support can be provided there. But from what we did find, it sounded like that sort of technical one-to-one support with some of those very small voluntary sector providers to just work alongside whoever is responsible for data in those organizations in actually connecting up to MHSDS, understanding the guidance when it sort of comes through and the next version is published and the next specification is published, seems to be quite powerful and has helped in some of the areas that we spoke to in the Southeast. So really just helping to actually give some of that capacity or resource just for a short space of time to actually get things connected. And once the sort of data flows and processes have been set up, they tend to then be able to run quite smoothly after that. So maybe not the most direct answer, but hopefully some indication that there will be sort of work in that space.
Brilliant. Thank you very much.
That's right. Olivia, did you want to?
Yes, just to add to what you were saying, Roshan and I are presenting next week to the National Mental Health Equalities Data Quality and Research subgroup. So that's something that we can also share with them in terms of, we've had a look at primary care, or from a primary care perspective and a secondary care perspective, but to support the ambition of expanding mental health to non-traditional NHS providers, there might be another piece of work, as you were saying, Hayley, which is providing some specific support, which we keep raising around our smaller providers in terms of ability to feed data, good data, comprehensive data, and sometimes the disproportionate efforts required for a really small organisation to provide that very comprehensive and robust data. So we can take that to national colleagues next week.
That'd be brilliant. Thank you, Olivia.
Any other questions for any of our speakers, whether Roshan or Liz or Victoria? Or Steve? Any? Okay, so I'll just say a big thank you to you all for your individual contributions to this piece of work, which is really, really important in trying to address inequalities and improve better access outcomes and experience of care for people who don't necessarily have an easy journey navigating sometimes very complex systems of health and care. Thank you for staying for the 90 minutes. We will, in terms of next step, upload the webinar, and I'm looking at Steve because that will be some of his work on our public-facing website, along with a clinical case study and the flyers and posters. It will take a bit longer to get to the animation. We will probably then continue with David being option 2, or option 2 will become our David, and we'll keep you up to date and share the animation when it's available. So thank you very much, and